pharmacy side. Of course, NCPDP is the standards development organization that supports a lot of these pharmacy standards and transactions. And so we recently had our annual conference. I was elected in as the chair of the board of trustees. But part of the reason we actually asked Daniel to come and present about e-consent is there's a lot of just use cases, even within pharmacy, that e-consent becomes important. Just one example, specialty medications. Doctors are, essentially, when they go to prescribe a specialty medication, it's not as easy as just sending your generic drug to a pharmacy, right? There's oftentimes you've got to have additional clinical information. Sometimes these medications go to what we call a hub. These hubs are essentially contracted with pharma manufacturers to make sure that a patient, because they're usually really, really expensive drugs. And so those hub services help provider or patients figure out how they can actually get their drug covered, things like that. And there's a lot of consent involved with that. And so, trying to capture consent for specialty medications is one of the topics. The other one is just around, pharmacists and what they're doing today with COVID, right? The immunizations, the testing, really they're on the front lines of doing all this. And then, so pharmacies now getting involved with how do you share that information back to the provider? How do you send it to public health, departments? Like here in Arizona, I did a drive-through for 2 of my vaccinations, and then I went to CVS to get my booster, and I have no way to connect all those records together. So, consent plays a role there. So, in any case, what we did is because NCPDP and Stewards of Change have an MOU. We also had the wonderful opportunity to have one of the artists come out and do some of these murals. The one that's on your screen right now is we actually had Dr. Jerome Adams, who was the former Surgeon General, come and speak and talk all about equity and just all the things that are really happening today in the industry. So it was a great conference. I, as chair, kind of one of my goals is to make sure people understand that we can't be in our pharmacy and medical silos anymore. There's just so many things that are crossing between the two. And, we as standards development organizations, we as industry folks need to be thinking pretty broadly. And that's what I love about this group, right? I mean, you guys are trying to connect people that usually aren't connected. And, I see a lot of that in the pharmacy space as well. I think, we have a little bit of a leg up because, we do have, pharmacy systems in place, things like that. But how do you kind of connect everything together? So Daniel was able to present on e-consent at the event. We also had the artist and just lots of things happening. So happy to answer any questions offline if anyone has any. I know we have a lot to cover today, but yeah.
Thanks, Pooja. We actually got Jim and Pooja and I got together and had drinks and dinner.
That was fun too.
That was amazing.
It was.
It was really quite something. And it was 90 degrees.
And it was 90 degrees.
And the desert was in bloom. It was so beautiful out there.
Yeah, so, it's a little warmer now. 102 today. So we caught the weather at the right time.
That's great. Yeah, so, this obviously the connection point here with advanced directives and the work on the actual consent. You didn't mention that, but Pooja and Ed Daniels and a bunch of folks from Point of Care were really involved with the scan and the whole model, especially through IOI and MELD, and sort of trying to wrap all that stuff together so we actually have the ability to not only do it but actually to manage it and implement it in multiple places. So that's cool. So. So we got a couple things we want to talk about. I got a couple new people, I think at least one new person on the call. And then Rob, I don't know who Rob is in 617. I'm not quite sure who they are. So we'll ask them to introduce themselves. So our custom Zach is, you get hazed the first time you're here. So no, I'm joking. Just say where you're from a little bit. I had a great fortune we were able to connect this week. Kathy introduced me to Zach, and we had a torrid conversation around the overlaps, especially in New York City, and just all the great stuff they're doing with CBOs and referral networks and public health. It's great. So anyways, just say a few words about what you're doing, and welcome.
Thank you. Good afternoon, everyone. I'm Zach Hennessy. I'm the Executive Vice President and Chief Strategy Officer at Public Health Solutions, which is the largest public health nonprofit in New York City and the city's Public Health Institute. The work that I think brings me to the table here is our healthcare community partnerships work, which attempts to build trustworthy and reliable pathways between healthcare systems, managed care organizations, and resources in the community that address the social drivers of health. And as part of that work, we have established a citywide community resource network of close to 300 community-based organizations offering a broad range of services and supports that is connected via technology on a single platform. But part of what we're trying to think through is how do we connect that platform to the larger technology ecosystem that would be required for a truly seamless participant experience. And I recognize that at the heart of that problem is the need for some form of universal consent. So I was very excited about the opportunity to hear about the work that you all have been doing, and happy to connect with any of you if there's deeper interest in our work.
That was an invitation to invite him to work groups, I believe.
Yeah. And also, and also for you to join, any of you to join us on our journey who are interested.
So that's great. Welcome. We'll be talking about a lot of stuff going on that intersect there, and great kudos to Kathy for making the introduction. Thank you. So anybody else? Rob, which Rob are you?
Rob Longley. I think that's me.
Okay.
I've been on several of these.
Okay.
I just am calling in from my phone, so it might look a little different.
Okay. Remind me, Rob, where are you from?
So I do consulting in public health for state of New Jersey, state of Connecticut, and I've done a lot of stuff around data exchange. And Brian and I got talking, and he got me invited to this. So happy to be along for the ride.
Excellent. Welcome.
And he lives just a county away, so we're neighbors.
Yeah, we got to get together.
At least as far as rural communities are concerned.
Yeah.
I think I remember that connection. You guys discovered you were nearby and you were going to have lunch one of those days.
Yes.
The opportunity presents. The only other person is 617. I don't remember that. Who's 617-763?
I think that's Adam.
Oh, right, of course. Of course. I will put him in there so we don't forget that. Anyway, we're going to do just a couple things today. Christine and others, we met with early intervention folks from New York City, kind of going sort of deeper into that case with some of the subject matter experts, Paul and Kathy and some others were here. So we're going to do a quick update on that. And then it's in part of the evolving case study. And then I asked Brian to sort of lead and orchestrate a conversation around a sort of a V.1 of the architecture that we can look at to do this consent work. And he's been building off a lot of the materials that we've been working on for a while. So it's really kind of a working session towards that. And both these things obviously both feed into the European Social Network meeting that was coming up in a couple of weeks that Jim and Christine will be at. And we actually recorded Mickey Tripathi and have him coming in virtually, so you'll hear his voice and that'll help with sort of describing from an architectural perspective, or at least being able to respond to that. So that will be great. And then as importantly, the the presumed ONC workshop on consent mid-August. We've got a tentative date of August 16th, so that will be potentially one of the tracks is on the technology side and architecture. I'm just saying, just guessing. But so we got a good jump on that to be able to talk about it, integrating a lot of the LEAP work that's going on and some of the open source stuff and stuff like that. So we'll go through that a bit. And then, and obviously, you know, kind of what's coming up over the next couple of weeks is a little variable with Memorial Day weekend coming and people beginning to travel. So with that, oh, and Robbie from California is on as well. Robbie, welcome. Some folks are joining the California network as they're looking at rolling out whole person care across the state of California on new legislation and their 1115 waivers. And Robbie and his group, Blue Path, are right at the center of that sort of coordination, collaboration across the state. So we've been learning a lot about that, and obviously the role of consent plays across all of those places as well. So I think we had, I know I shared some of the material with some of the people here. We probably, I think I asked Amanda to put it on the hub for people who want to find it. But before I turn it over to Christine, can you just, do you feel comfortable just giving a couple of minutes sort of high level overview of what's going on there? Because things are moving fast and furious, it sounds like.
Hey, Daniel, this is Robbie. Did you want just a summary from California right now?
Yeah, just a quick one. That would be great.
Yeah, so things are certainly moving quickly, and nice to see those of you who haven't met. I'm Robbie Franceschini with Blue Path Health and Connecting for Better Health, which is the California-based data sharing focused coalition. Really right now, we're kind of sprinting in the state towards this July 1st deadline by which the California Health and Human Services Agency needs to publish a data exchange framework for the state, as well as a data sharing agreement and related policies and procedures. This is under a law that was passed last year as part of budget negotiations. And right now, you know, what the law lays out and how things are taking shape is that California won't be pursuing, you know, a single statewide HIE or really kind of creating a network, but really creating a data sharing agreement, an environment whereby health plans and providers are required to sign on to a common data sharing agreement by which they need to share, you know, health information as required under the data sharing agreement for treatment, payment, and operations purposes. It does contemplate social services sort of within it right now, but I think, to be honest, a lot of work remains to figure that piece out. And I think that the data sharing agreement will really, you know, start with healthcare organizations or HIPAA covered entities, and then the state will really have to take on, you know, the rest of the work to figure out the social services piece. Additionally, I think, you know, consent and consent management is a key piece of the work too. And the state is also including in their data exchange framework this digital identities framework. I think rather than going the whole way and going towards sort of a single consent management approach, it looks like what they are going to propose to do is come up with a framework by which participants in this data exchange framework will have to manage consent in the same way in some fashion. I think they're still kind of ironing out what those details will look like. But it also doesn't look like the state's going to go with kind of a single solution, again, if you will. So right now, stakeholders have until next Wednesday to provide public comment on the draft data sharing agreement and framework materials that went out. And we'll be sharing those with our you know, participants and many of you who are on this call, you know, for input as to, you know, how our coalition can respond as well. And I see you on here too, Jim. Hello. But yeah, happy to answer any questions folks might have.
You know, Robbie, I think that I just was going to put a kind of a Just a kind of a challenge in the chat here. I'm worried about sort of the fragmentation, and it would be interesting to be able to. One of the possibilities, really the audacious possibilities, is to line up California and New York and see if we can actually do something in common with a couple of states in the middle. And that's the conversation we want to have. I mean, it's audacious that we should think about it at that scale, but in effect, you know, that's what we need to do, or that's what at least we can try to at least raise the conversation to that level.
And I would just add for this group, between this group and C4BH, there's nothing wrong with a clinically oriented consent model to start with. Obviously, this group and our broader goals are to include social services, but for where you're starting with C4BH, if the focus is just around consent to share for data exchange from a healthcare perspective, that's also fine too.
Yeah, that's a good point.
Robbie,
Yeah. Oh, sorry.
That's right. This is Courtney Baldridge from US Aging. So are they looking to align all the data in and empower data exchange across the various entities that are playing, so to speak, managed care, clinical, and potentially social services?
I would say that's the goal. I think California is taking a unique approach to doing this. So I think it's been challenging because the state hasn't taken this approach before, right? Like generally states have, you know, gone with a designated entity or designated entities and you know, formed like an HIE or a network of HIEs. And so the state is trying to, you know, promote data sharing through this common agreement. I think what it'll look like in the end is there's kind of three options in my mind for sharing data. And if I'm thinking from a healthcare context, it's like join one of the qualified health information organizations that exists in California who can share and receive the data on your behalf. You know, use something like Care Quality, you know, to be able to put out a query and receive information and share it. Or this sort of third bucket, which is where I feel like a lot of, especially what they deem social services organizations fall, which is do something else to figure out how to meet the data sharing agreement requirements. And I think that's where it's really sticky. Yes, common agreement makes me think of TEFCA too. I think, you know, in the state, folks are thinking like TEFCA doesn't go far enough necessarily for data sharing needs. You know, not every HIPAA use case is a required purpose for data exchange under TEFCA. And I think they're the other, you know, the missing pieces there too, I would think are around public health as well as social services too, which have been of interest to the state. So I think that's where there's some divergence in addition to this data sharing mandate that, you know, organizations as specified under law have to share data versus TEFCA, which is voluntary.
And Robbie, is there an expectation that the data will align?
Yes, so there are, and what are the policies and procedures? You know, they have outlined like the standards that need to be used, you know, USCDI, HL7, but you know, there's variation even within that. So I think part of it is this will be a process. You know, the state has put out the draft data sharing agreement as well as 6 policies and procedures. And I've said, you know, they're looking to put out more policies and procedures and refine this over time. Once they have a governance model in place.
Robbie, when you talk about, Matt Bishop, Open City Labs. When you talk about not a common solution for consent, would there be a convergence around a common standard for consent? I mean, even if you're just keeping the focus on the clinical use cases, there's obviously a lot of breadth outside of treatment, payment, and operations, especially when you're talking about, you know, integrated primary and behavioral health care or 42 CFR. So there's obviously, even if you're just still focusing on clinical, there's implications to, coordination of care if there's not a standard go ahead.
So they've talked about creating a standard form that organizations could utilize, but they haven't, it's sort of like on the roadmap in
Got it.
terms of that. And I think something more robust seems even kind of further off. I think right now, really where the data sharing agreement is the requirement to comply with all applicable law, right? So if you need to get an authorization or a patient consent to share data, then you have to do that. Like this agreement obviously wouldn't kind of supersede that.
So that's a good transition. Actually, that data sharing agreement, if I'm not mistaken, is was originated actually in Illinois with a precursor in Virginia. And it's, I believe, I haven't read it closely lately, but it has been growing in terms of the ability to bring the agencies together and bind them in a way that they haven't been bound yet, requiring them to do all the hard work still has to get done, but at least they're in relationship to one another, which is helpful.
Mm-hmm.
Right. So, and social services is, well, we'll lead the East Coast will lead the social services integration at the Bronx through the EI use case. It's a long haul, but it's time to think ambitiously about that. And one of the things we talked about, and then I'll turn over to Christine, is I was on the call and I raised a question about not the question, but the observation from Chris Albatrani from the Network for Public Health Law, who reminded us that care coordination is also, sort of acceptable in addition to TPO as for integrating it. So that was kind of a outstanding question that I think needs to be revisited. I think it's a big opening for social services not to be left behind. Because what will happen is, like everything, it'll never get to it. It won't happen. So it needs to be into TEFCA. The language needs to be there. It needs to be in Gravity. It needs to be in everywhere. And you need to do it. It needs to be in the, the ONC roadmaps and the accelerator sites. So.
And Daniel, I would add to that, I think it's critically important not just to leave it behind and not for it just to be included, but there are the appropriate social care stakeholders involved in what that looks like, because on numerous occasions we have seen, whether it be Gravity, whether it be, there's some models that we know are rolling out now where there were not appropriate folks at the table, where there's some significant disconnects and serious disconnects that make it harder to clean things up on the back end. So I think certainly Robbie would love to have some conversations with you about certainly the unique nature of our network. And there's some other networks that are nationwide. So we become more inconvenient because we have certain mandates and requirements that are nationwide because we're federally funded. And those don't go away despite what everybody else creates. And oftentimes things don't align quite as neatly as other stakeholders hope.
No, I agree. And, I think looking at who's on the data exchange framework advisory group, there really aren't social services organizations represented. To that extent, it's the closest thing is mostly county agencies, which it's a little bit of a step in the right direction, but I think insufficient. And, one thing we are hoping to do in partnership with the Insure the Uninsured project in California is convene folks in a series of workshops to stress test, if you will, this data sharing agreement, against specific use cases in social services. My hunch is that this data sharing agreement won't really meet social services needs. It's very healthcare focused, covered entity focused, which I will say, I think for California is a major leap if we can actually get this thing in place and people sign it, after a decade of kind of, fits and starts at better data exchange. But agree that, we need those stakeholders in the room to help shape this, from social services, and, would love to follow up with you and others who are interested, and also gather your input too on how we can utilize our coalition to help kind of steer the state in the right direction.
Sure, happy to do that. And I will tell you, and I think some of the people on this call, where I'm on calls in other places with them, it's a lonely place to be on the social care side and be in these rooms. So the good news is I've been accepted by everyone else. Thank you for tolerating me. But yeah, there's not many of us that are showing up in these rooms these days, and it's an important space. So thank you.
Yeah, would love to have you.
Hey,
Just,
Daniel,
yeah,
it's Dave Walsh. I've got a question for you. As I look at these diagrams, which I've always really been amazed at the real-time nature of creating those. My head can't go as fast as the artist can go. But when I look at this, I look at it as kind of a very abstract flow chart. Here's what's going to occur as the data moves on and so forth. 2 weeks ago, I think it was, Mary Kratz started talking a little bit about BPMN and activities that they've got going down that path, which BPMN stands for Business Process
modeling.
Say again?
The BPM plus folks?
Yeah, BPM plus, but the standard is Business Process Modeling Notation. And we're talking about the same thing, but the plus adds some extra capabilities on there. So my question now is, have we looked at that so far, the BPMN, as a way to express or diagram the business flow? I know we've done proof of concepts when we click a button and we say, trust us, something magic happened behind the scenes and so forth. But we really haven't had a whole lot of, here is the business process and the decision points and everything to model that going forward. Do you know of any of us that are looking at doing that at this point?
Yes. Okay. Jim, you want to?
Yeah, I'm a member of BPM Plus Health, Dave, and that's an activity underneath OMG, the Object Management Group.
Right.
And they have already been doing over the last couple of years e-consent BPM process flows and models. And what Mary's hoping to do through the combination of the open source sandbox project they have and what we're doing in Project Unify and some of the other ontologies work with BPM Plus Health and their BPM men work to develop that sort of model. So you could ultimately look at, I think a future world where there are various BPM notation models to fit certain regulatory guidelines or business cases and workflows married up with HL7 FHIR, NEEM ontologies, etc., for all those parts and pieces to move in accordance with a governed rule model.
So there is an initiative ongoing, Jim, is that what you said?
Yes, there is. There's an e-consent workflow project in BPM Plus Health.
Okay.
Dave,
do you happen to know what the plus piece of that is?
Yeah, well, the moniker is designed to imply that business process management rules would be applied to healthcare use cases. That's why they call it BPM Plus Health.
Gotcha. Well, good. You'll have to let me know who's active in that, because I've done quite a few systems in BPM and would like to find out where things are going there.
Yeah, sure. I'd be happy to email you with the details on how you can join OMG and participate.
That sounds great.
Sure. Daniel, go ahead, Daniel. I know you got.
Yeah, I've just been a couple things. I thought you were going to say the plus was kind of supersized, maybe, but we actually were trying to get BPM Plus folks here on this call or next week or the week after. So Mary's been wrangling. So Jim, maybe when we talk to Mary and whoever talks, she's been trying to reach out to them. We had them present a couple of weeks ago with the advanced directive that Pooja has sort of facilitated that part of the conversation. And so we recognize the value of that, especially from the HIMSS interoperability showcase. I really became a convert of being able to do that. And so Christine is actually doing the use case and will be has been, sort of connected to how do we take the early intervention and use the knowledge and the work from BPM and the advanced directives. And so we should be on that conversation over the next couple of weeks, whenever they're available and whenever we can have sort of a reasonable conversation. So
that's great, Daniel. I think it's really, really appropriate.
Great.
Yeah, the other overlap there is that the HL7 Passio group, which I think Rita and I are both part of, and she can speak up and correct me, has been doing a lot of work in the advanced directives interoperability world with Maria Moen and AD Vault to lay out from an if we move from the traditional CCDA advanced directive model. And for those who don't know, advanced directives is kind of an encompassing term for medical powers of attorney, DNRs, that sort of thing. And we start looking at those as digital and electronic and what they fit into different state laws around electronic notaries or paper notaries, etc. There's a BPM model that can go on top of that, which has been largely the focus of eConsent.
Super. Thank you.
So with that, Christine, you want to talk some about the EI conversation we had?
So like Dave, I've been very distracted by having this diagram continue to be on the screen in front of us, Daniel.
All right.
Let me ask one question about it before you take it down. You took it down too fast. All right, you still have to tell me what the 88% and the 12% were.
Oh yeah. Do you remember that? That was, I'll pull it up. I get it.
I don't. I'll have to look at it again. I'm trying to remember my.
It was like spending was down 12% on other stuff and then up 88%, but I couldn't tell what words.
I was taking a
were
bunch of
attached
notes
to
when he
that.
was. Yeah, I was taking a bunch of notes when he was talking. Of course, I don't have him in front of me.
All right. Well, you can get back to us another
I
time
will.
with the answer to that.
Oh,
So it was in the center of the screen, and I just kept looking at it, trying to figure out what it referred to. So.
Oh, funny.
All right, next time. All right, so just very briefly, I want to give a really quick sort of recap and update on the early childhood use case, because I really want, I'm looking forward to Brian's presentation of the technical solution to this, instead of just sort of talking in the same sort of circles about the programmatic side of things. But very, very briefly, in terms of recap for anyone who's new or hasn't been on the call for a couple of weeks, for the consent service utility, we've been building out this use case around early childhood and specifically focusing on the early intervention program, which is a U.S. Department of Education program that typically lives inside of state departments of health. So that in and of itself makes it very, very interesting because it's sort of crossing domains in terms of administrative issues. So apologies to Courtney, because this is living on the other side of the age spectrum from where she's at, but I think the issues are very, very similar. So in early intervention, this is for kids who are 0 to 3, and they get referred into early intervention for evaluation and possible treatment. And treatment means things like speech therapy, occupational therapy, physical therapy, and other types of treatments that are supposed to be delivered to them in their natural environment, which might mean their home or might mean their childcare, other settings like that. So these are treatments that are delivered to them, not in a medical setting, but in their so-called natural environment. And so the kids are referred into it. In New York State, we found out that they are typically referred in by primary care, but there are many, many other people who can refer and are, quote, required to refer children into this program. Interestingly, they don't get referred in because they're on the birth defects registry. that information goes to other public health programs, but not to early intervention. And then at the end of this process, if the child's issues, if they qualify for services, receive services, and still have issues as they are turning 3, there is supposed to be a formal handoff to the local education agency on the other end, because then that local education agency is the one that is required to pick up and work with these kids to ensure that they can be as healthy and ready to learn as possible. So we had a discussion, actually not with New York City's early intervention program, but with New York State's early intervention program. And that was good and bad. It was good because we learned that from a consent standpoint, there are many opportunities for improvement. And what I mean by that is, let me actually just first review the places where consent are needed. So essentially, if you're looking at early intervention, you'll have either data coming in or data going out. So for data to come in to early intervention, in order to help them evaluate that child and at the beginning and reevaluate them, which they have to do every 6 months, you would imagine that there's obviously healthcare data, which would be subject to HIPAA, or data, say they're referred in from childcare or referred in from Child Protective Services, then you would have data coming in from those various agencies, all of which would be subject to whatever is required to release information out of those agencies to early intervention. And then you have information that could come out of early intervention, which would be the evaluation, the service plan, and the every 6-month sort of updates on those evaluations and service plans. And that information would, of course, be useful to that child's primary care provider, some other specialty physicians, potentially like neurology, for example, and also be of use to the daycare center where they spend many, many hours every day, and to, again, to the child welfare agency as, you know, kind of our sort of core set of things where that data might be useful. It is very clear from both federal and state law and regulation that anytime information leaves early intervention, that the parents have to give explicit consent, with one exception. The one exception is when that child is going to be turning 3, the local education agency can be given that child's name and contact information, but that's it. So again, no explanation as to why they're being handed off to the local education agency. So just that there is a kid that's been in early intervention, been getting services, and might need to get services at their school. So again, for any specifics to leave early intervention, parental consent must be obtained. There are no regulations either federally or for New York State that tell us whether a blanket consent can be given at the beginning of a child's early intervention journey for all future things, or nor is there anything that says it has to be done every time new information is generated about that child. So in theory, a blanket consent at the beginning of their early intervention journey would be okay. Now, when I say it was both good and bad that we talked to New York State instead of to New York City, from my perspective, that's because we learned from the state that there are no consistent processes or consent documents. Every single county, plus the 5 boroughs, are responsible for implementing early intervention, and they can all do it, you know, however they do it according to law and regulation, but they do not have specific policy and process documents, and they certainly do not have single consent documents. Essentially that's true. They did just develop a consent for treatment that is electronic, and so that document is the same across the state, but the consents for releases of information, it did not sound like there's anything that is consistently applied around the state. So So that was very interesting to learn, and it shows what a tremendous opportunity there is for something like a consent utility service that actually includes the consents themselves as part of that service, to really make things easier for, in this case, I think it was something like 57 agencies across the state of New York. That's not what we're focusing on. We're only focusing on New York City, but it just shows, again, this huge opportunity. This is a huge administrative burden. Oh, there's only 58 in California, despite the figure size. So it's a huge administrative burden on all of these local agencies to figure this process out. It's just to come up with acceptable forms, to come up with policies. I mean, I just think that's sort of a crushing administrative burden. And the other thing that was interesting, I think, from the discussion was that because this is so hard, it's so hard to both pull information in and to push information out. I got the impression that it just doesn't happen a lot of the time, which is completely consistent with my experience in multiple other states. I've never practiced in New York, but I've practiced in 4 states. And in my experience in those other 4 states, the information flow just doesn't happen. And they were very clear that, really what they depend upon is that initial referral in. So if that initial referral in is not very detailed, that might be all that they get. And then they just start fresh. So, they are really, having to reinvent the wheel when it comes to these kids. So you can really see, that there's potentially a lot of duplicative effort. There's a lot of administrative burden. There are so many things that truly could be made better by having this process in place for information to at least be allowed to flow. Then, of course, we've got to figure out how it flows, which is a whole other story. But anyway, so that's really my update from the discussion. Clearly, we are going to need to dig in a little bit deeper with the program as it is implemented in the Bronx, so that we can, really help the BE Inc. program to move forward to really be the pilot for this.
So this is Paul. I just wanted to say, we thought that this was just going to be an incremental thing, and it sounds more revolutionary than incremental.
Yeah, I mean, I think it's really transformative in terms of the way that people potentially do their work. And, to Courtney's point earlier, I felt like the main person that we were having this conversation with the other day, like smoke was probably coming out her ears. We actually couldn't see her. She was just on the phone or just on the audio. But I think I would love to know her thoughts today about how this conversation made her think about, wow, like we could really do this program in a much more robust fashion if we could just get this information exchange business solved, which just often bogs down around the consent issue. So yeah, I think it's a huge opportunity and pretty revolutionary, but we need to make sure that we bring them back to the table to tell us about their thoughts about it from their end. Like I can speak to the physician's end and talk about how important it is that I get those records out of early intervention. And particularly if you want me to sign orders for therapy, I don't want to sign those orders if I don't have the records. That's not, I should not be doing that. But there's opportunity on their end as well. So I don't know, Courtney, if you looked like you might wanted to chime in there.
Well, let me just say though, I thought that she was fabulous, and she really answered very nitty-gritty questions, right? About her perspective, and she had a lot of experience. So I thought she was great, and she had never thought about this. She was very intrigued by the thinking going on here, right? She had never really considered this stuff. So it really can be very transformative, and so it's a real opportunity to think about it.
And I'm just looking at Zach's comment, and that's exactly it. That's my starting point. My starting point is the families telling me, stop making me do this 17 times. Like I want, why can't I just give this information once and everybody shares it and it's in the right place at the right time. Why do I have to be the one to carry around the shoebox or the giant binder? And
you show up and
just what they do.
And you show up and the providers don't know anything. We were just dealing with some aphasia in our family here, but we're lucky to be in Canada. So the speech language pathologists and the specialty providers and the hospital all have access to the whole picture without any
Very different,
without
very
any
different.
consent.
Well, I'm fresh off of taking a child to the hospital yesterday, and he's fine, but has a horrible, horrible case of mono. So went through the tedious process of repeating the information about 100 times, as well as then got on the phone with the PCP and repeated everything a few more times. And I think that one of the critical things is you start with the consumers, the patients, the consumers, the caregivers, and what they go through with that. What are their needs with the data and how to respond to that? But then take that all the way through the chain, because each entity that's involved, whether it's a clinician, whether it's a service provider, or whether it's a payer, and that differs whether it's an MCO and what funded program they come through, everyone needs different types of data. They access it different ways, and oftentimes none of it aligns. At least that's what we see on our side. So it's that challenge of how do you walk through the system? The good news is that I think the MCOs are very well oriented in terms of working with clinicians, and I'll give credit back to the birth of the electronic medical records and the HINs and those folks. I think that we should be more attuned to consumers because they've been around a long time, but I don't think that we've invested the time and energy to hear their perspectives often enough and granularly enough. And I think that the social care world just really hasn't been an issue at the table or given any consideration until recently. And as such, typically not at the table at the beginning of the conversations.
I see that Robin just put a comment about the intersection with child welfare. And we did ask a few questions about whether there were established processes. And it didn't really sound like there was anything that was a well-established process. So, clearly sometimes the state becomes custodial, and then, that's pretty clear. But when they're not, it just sounded like, again, at the local agency level. So again, 57 times in New York, people had to figure this out and exactly how to work with their child welfare agency.
So the good news is we have both OCFS and Department of Health, and well, probably ACS as well in the city, at least involved, interested to a degree, definitely DOH, and the Office of Children and Family Services is. I actually emailed Commissioner Poole this morning to say, let's look for a date to get together and figure out what the intersections are with child welfare. So so it's there are. So the good news is we actually have a lot of people at the table. So we just need to continue moving forward. So,
Daniel,
yeah.
I just to follow up with my question or and Christine's message on that, they're the highest at risk kids. They're coming into this system, if you will, having suffered various levels of trauma. I mean, a lot of us on the call know about the ACEs study and the longitudinal effect of childhood trauma on healthcare and so forth. And so, for entities that are part of the work that Christine is describing and yourself, Daniel, in those particular states, I can't imagine that anyone has to really present the compelling argument to really be paying attention to these kiddos in the context of those types of lived experiences that they go through.
But to move people to action is, I mean, if everybody will agree, everyone will admire the problem vociferously, but to take action, to share data, and we know child welfare is the most difficult agency to move data out of, more easily moving data into it. So good news is Kathy and Paul and Inc. New York has a relationship with the city's Administration for Children's Services, and now the state is also involved. And actually, I'm speaking with the Children's Bureau folks in the next couple of days as well about this. So we're lining up federal, state, local, community, county, community, person level. That's the goal, is to really, yeah. So I don't know when Brian is back. Brian had to step away for a second. I was just going to hand it to him to the architecture, but we have a couple of minutes.
Well, I was going to point out, Daniel, that once the child's in the school system and subject to FERPA, FERPA does have a very specific exception for working with child welfare, but that doesn't. And that's why, in some ways, it's unfortunate that early intervention doesn't fall under FERPA, because then that means that exception is not there. And so it would just be, it'd be neater if it was. And so then we would have the exceptions for communicating with both the justice sector and with child welfare. But none of that is spelled out in any of the laws and regulations specific to early intervention.
And I just respond a little bit to Robin. We only had an hour to talk to them. So, those things can come up next. Right?
Yeah.
I think one of the things that's interesting in this broader space is where there are entities or networks that are nationwide and standardized. So you enter that network and they are primary, and that's kind of, because of Older Americans Act, that's our AAAs on the ground, versus networks that are a lot of different smaller entities providing services, where you're trying to connect up who should be involved, who should get the data, and who it should hand off to, who's on first base at which point, and how you hold those various entities together as a network, and how you then do share the data. And I think we're very fortunate at the AAA side, because we have a mandate from Congress, we have the Older Americans Act, we have certain data sets. They don't all align across the state, but we do have standardized services we offer, and we know who sits on first base with those. I look at other things, whether it's homelessness, whether it's pregnant women, and trying to bring those universes together becomes tough. And because there is no structure and there are no rules of the road, so to speak.
Yep.
So I think that we need to think networks versus kind of the disparate on their own community-based organization, because there's two very different challenges.
Amen. So let me hand it over to Brian. For those of you on the call, we'll go for another half hour or so. If you got to drop off, please, we'll continue to record it. But I wanted to have a chance to sort of air this out. We'll have it on recording. Oops, that's, oh, there you go. Thanks, Brian. Take it
Oh,
away.
you're welcome. Welcome. Can you see the full screen here?
Yep.
Okay, it's not covered over by one of my other windows. Good.
Nope.
Okay, as preface, this is an early draft presentation, or you can think of it as an early draft of an architectural model. It's largely just me thinking out loud in PowerPoint slides. And you should also note, each of you who have received this via email, that the speaker notes don't mean anything. They're leftovers from cut and pasted slides and duplicated slides. And so ignore all of that. I didn't discover that until I went in to sort of update a bit of speaker notes for this particular sharing of it. and realize that the speaker notes are just all screwed up in the version you have. So proof positive, this is an early draft. I'm not going to actually present all 18 or 19 slides here. I'll present with 18 slides. I'll present with some completeness about 2 of them, maybe 3 of them. So feel free to read the rest of the presentation on your own, or if you've already read through it and you go, hey, wait a minute, I really wanted to talk about slide number 15, you haven't gotten to it, then I'll bother with sharing the rest of the presentation. So now let's hope I can make this work. This is one of the slides that I'm going to speak a little bit on, because it sort of sets up everything else. And so I'm going to read you my speaker notes and deal with messages on most of the rest. With the advent of social determinants of health, we have a lot of different systems across various social care and healthcare domains that need to be able to exchange information. Where just one system needs to share information with one other system, consent is simple. The system sharing the information can look at its internal access control lists or records or consents to determine if the system or person with which it is sharing is allowed to access the data. However, as the number of different systems that need to share information increases, we run into 3 different problems. One is that a system receiving information from lots of different places may need to share some of that information with another system, requiring it to go back and request for permission to reshare that original record with the original system of record. This requires knowing what system the information came from, number one, a provenance problem, but it also requires you knowing, how do I get to that system? What standard does it use? How do I ask for that permission when consent standards differ from information domain to information domain, or in some cases are lacking altogether? The second problem is that if a case manager or care coordination gets a patient or client to sign a universal consent form to gain broad permission to exchange data, well, now that case manager or care coordinator needs to know which systems of record they need to register that consent with. And of course, we still have the problem with, in the absence of consent standards, how do you know which protocol, which API, which user interface to use to register that new consent? And the third and final challenge is that the individual about whom that information is stored needs to be able to find out which systems have sensitive information about them, and then needs to figure out, well, how do I assert consent or privacy preferences through the many different and likely, frankly, confusing systems that are available to them. So, oh dear, I didn't realize this was a Build-A-Bear slide. Sorry, this is one of Daniel's slides.
Draft. It's the arrow.
Pardon?
Proceed.
I will fix it in a later version. So basically, this is the, what's the problem statement? What do we want to do as a consequence? So I'm not going to present this slide. We've all seen it multiple times before. Went a little too far. So of course, the goal is to try to get a single common consent service utility that will work with all of the different systems that need to be able to share consent, share information, and therefore have access to consent, and provide a common mechanism through which the end user and the case manager, care coordinator, etc., can interact with those consents for management purposes of those consents. So instead of it being, lots of information going all over the place, well, there's still lots of information going all over the place, but at least each of the systems is coming to a single logically centralized service to find out whether or not it has consent to reshare, consent to change. Yes, Daniel.
Quick question, just a quick poll, show of hands. Do we think should child welfare have its own icon?
Yes.
Oh, absolutely, it should. I'm sorry, have I missed it here? This is intended to be representational.
No. I'm just, it's working. I'm just saying, I think it needs to have its own call out because it doesn't fit. I mean, it's a social care case management system, but it's kind of, so anybody disagree with that? Okay.
I don't. What I'll do is I'll move the social care case management thing up to the top here and put child welfare in between family court and housing choice voucher.
Great.
That actually fits in well with one of our use cases in any case.
Just a question, is that term child welfare commonly the vernacular when you think of children who are involved with child protective services? Because that's really the case that I'm most concerned. Okay.
Yeah.
Well, also in foster care systems and adoption systems.
Okay.
They
Thank
also
you.
have responsibility for half of juvenile justice.
Rich, what does PCSA mean?
Pardon?
No, Rich put in a PCSA acronym. Oh, public.
Sorry, yeah, I was trying to get off mute. Yeah, and some of it just, they're referred to, especially from local, state, and state to state. And when you look at some of the ACF stuff and Children's Bureau stuff and workforce stuff, I've been using PCSA more just as a public children's services association or agency. So it can kind of house all that, especially I appreciate someone calling out the adoption part, youth who are emancipating, and even as some of these children and our youth start aging up and are still looking to those agencies to help coordinate some healthcare, mental health care, substance abuse treatment, even as they are in early adulthood. So I've been trying to use some of those broader terms.
Right.
I
Good
think
idea.
because I'm very visual and spatial, one of the things that would be super helpful to somebody like me is what is the pathway for a child in terms of where do they typically land first and where does their paperwork migrate and travel? If there's any type of
To your earlier point, Courtney, there is no typical pathway because it's not organized.
So but is there one entity that may have, a majority or seem to be kind of the lead spot? Because what I will tell you, I know at least from our network, is whoever holds them first kind of dictates that initial flight of information based off of their assessment, whatever that is, based off of their platform and everything else. So having line of sight to maybe of these, however many are populated on this screen, that there's 3 or 4 of them that may be the most typical starting places could at least be helpful as you think this through.
So Courtney, this is why we have the use cases really, because it's so situational, right?
Okay.
One situation is different. I mean, in your world with the AAAs, it's already almost pre thought through, or there's a pathway that
There's a
AAAs,
pathway.
it's imposed, let me call it. I'll say it's already imposed. Yeah. I mean, so sorry.
Some places, like people might just be sent to their county human services agency, and there might be a big picture eligibility and enrollment person who really does kind of check the boxes and say, yep, you can do this, 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 and this, and helps to get them enrolled in all of those. But that I would not say that that is the rule. That might be how it could happen, but sometimes these are all in different agencies. And they may enter just into one. I mean, when I was in Hawaii, everybody knew about WIC and everybody entered WIC, but they would never really have considered anything else. So unless somebody really sort of made a point to them of, oh, you also would qualify for this other service and should go there. But it was just very accepted that people would use WIC. People didn't really think of it as welfare.
I would
And
point out that I would-
just
I would
one quick comment, Brian. So one of the things that really happens, and one of the things that came forward when we were doing the interviewing the other day is, the rural areas are going to be very different than the urban areas, right? The rural, it's going to be, there's one place, and you're lucky that there's that one place, right? Versus the urban areas having all sorts of differences.
The other thing is when I made my not very pretty diagrams, I did put everything that's not means tested on the first slide and then started layering means tested programs after that, because I think it's important to also realize things that could potentially affect any children regardless of their family's income. And then there are many, many programs that are restricted based on income.
I feel the need to grab a hold of the conversation again here.
Yeah, we're not getting to what I wanted, the technology yet.
Now let's go to the hardcore stuff right away.
If you'll just let me finish, please. Somebody, everybody. This is not about child welfare. This is about consent. So.
All right.
Consent doesn't live on its own. It's not we're not working on this in isolation. It's part of an entire ecosystem that the folks in San Diego CIE created the LEAP CDS consent model, which is pretty good. It turns around and my apologies, I'm getting distracted by some background noise. Daniel, can you
just muted.
Whoever it is.
I just muted him.
Okay, thank you. In the San Diego model, you have a separate consent enforcement service that may be integrated in with an application, or maybe a separate redaction service. When you want to gain access to a piece of information from another system, presumably, you go through the consent enforcement service to request it from a consent decision service, which then goes to a consent discovery service to find out, well, where are the consents stored for this particular piece of information on this remote system of record. And then when those consents are returned to the consent discovery service, it also fetches the record itself. And that consent discovery service takes a look at what consents have been defined for that record, takes a look at what data segmentation for privacy, basically embedded privacy information, is in the record that it has received, if any. It also takes a look at what are the regulations and rules associated with the jurisdiction, your state rules, the federal rules for your particular domain. Takes a look at what organizational policies might be in place. And it also then uses who is requesting it, what role they're playing, what purpose they have for gaining access to this information. What do they want to do with the information? Do they just want to read it or delete it or modify it? And they do this marvelous little decision tree that results in an answer going back to the consent decision service, from the consent decision service to the consent enforcement service, of either yes, you can have access to the record and here it is, or no, you can't have access to the record and I'm not going to give it to you. Or 3, yes, you can have access to it, but we have some obligations, we have some requirements on you that you, the consent enforcement service, have responsibility for enforcing, such as, here's somebody's clinical record, but you can't show anybody their mental health information. You can't show them their substance use disorder condition. So that's how the consent enforcement service gets it. The consent enforcement service might be something as simple as the consent to share redaction mechanism, where the information in the record is simply removed from the record before it's handed over to the person, the application asking for it. Or it might be something as complicated as a CDS hooks in the middle of the workflow system that provides the specific piece of information that somebody is asking for rather than the complete record, while at the same time ensuring that they don't hand over information for which there were obligations. This is a great system. However, this is the challenge of copying things. I've copied too well, Daniel. It's got a good model. That's common. It's not encapsulated inside of an individual system. It's not specific to healthcare. It's supposed to be generalizable to social care, education, justice, etc. It's got a fairly well-designed architectural model. It's flexible, adaptable, modularized, and it's got an open source implementation, which is extensible and with which you can replace some of the code that currently exists with new code. What it's missing is that they haven't addressed in this model identity management. That should be identity, not identify management on the slide. And so we need to add in identity attestation, validation, matching, deduplication. There's no explicit record locator functionality there. We've got consent discovery, which implies record location. In some cases, that record location is obvious. You're handing over to the consent decision service, et cetera, a URL directly to the piece of information. In other cases, it's a search request. Hey, do we have any information on such and such a patient? So we need to explicitly reference the record locator functionality. And there's also implicitly it's exchanging record, but nowhere does it say we're pulling the record over from a record store somewhere. So there's some opportunities to improve things a little bit, but to do so in the context of, I guess this is an example of the law of unintended consequences. We've got a very simple system documented in the original LEAP CDS, which is better than the old model for consent of just ask if you have access and we'll tell you if you do. But it's still missing a lot of things. And as a consequence, our attempts to use this model for what we know to be a more complex system has resulted in a lot of our discussions to some confusion over what's in, what's out, what gets done by which solution that we've been talking to. So this is the final slide that I'm going to show. And we can get into the gory details in a different discussion. If you squint real hard, you can see the bones of the LEAP CDS. It's got consent stores here. It's got consent discovery. It has the consent decision service here in the computed authorization service. And it has consent enforcement, authorization enforcement. But we've added in a box, a service, a functionality for identity proofing, both identity assertions and identity proofing. We've added in support for identity matching and or deduplication, because even if you're talking about, for instance, a national ID, you may have somebody who's asserting their identity, have had their identity proved, but now you need to say, well, based on these proven demographics, what's the national ID, patient ID associated with them? And right now we don't have a national patient ID, which means that now we need to worry about, well, is this person based on proven demographics associated with this ID in this system, that ID in another system, these two IDs in a third system, and match those identities and deduplicate where necessary. Then over here, we've got a similar process of, can we find the records? It's easy if you just have a single URL pointing directly at the record you want to get at. It's more complicated if your request is, would you please search for all records that are available for such and such a person based on their demographics? And if you're asking for these pieces of information across multiple different systems, You need to worry about not just have we found the right records or records from one system and deduplicate them, but do we have multiple records coming from multiple different systems with slightly different variations based on both either typos, changes over time of information that weren't caught up in the other systems. So there's a good deal of work that needs to happen here. And then based on that, you need to do consent discovery and you need to do record access. So now we've pulled those all together into a single kind of logical box of go find my records and find out the consent information associated with those records. The final thing that we've done is I moved the end user consent management around to the top so that it's making use of consent discovery for finding out where we have consents, where do we have sensitive records, and therefore where do we have consents and privacy information, rather than expecting that the end user consent management component would simply know where these consent stores are, which was in the other model. Part of the motivation for doing all of this, and then I'm done as we're coming up on 5:25, is we've been in discussions with multiple different folks about different technology that could be used for implementing different parts of this. The Leap CDS and open source software provides some of this functionality. Consent to share provides some of this functionality, but Cardia.app provides some of this functionality. Magellan from AWS provides some of this functionality. The new standards consensus body within Direct Trust for privacy enhanced health record locator service would be providing some of this functionality if it gets defined in a way that's compatible and complementary to the needs of this system. So we know that there's a bunch of different technology out there that we could pick and choose from. The challenge had been that everyone thinks they do everything, when in fact, when you get down to the nitty gritty, no, we don't do that. Oh, no, we don't do that. So we need a model like this so that we can place the different kinds of technology in the right relationship to other technology that we need, and make sure that we are basically pulling together an entire consent ecosystem, not just pieces and parts of that. And that is my pitch. And for those of you who haven't read the presentation, slides, it would be slides 10 through 18, dive into kind of the next layer down for each of these little boxes. And frankly, they're even more draft than the slides you've seen so far. So, be patient with me, and please, please, please contribute, correct me. I am not omnipotent. And I'm only omnipresent, apparently, according to Matt. I'm done.
Right.
Only omnipresent in standards entities.
That's great. I think being able to speak the CDS LEAP language, or the LEAP CDS language, especially in our conversations with San Diego and California and New York and the HIEs, will be really important, especially if that, and the ONC, obviously, to see how do we take that work next. So we don't need to belabor this at this point. We're going to come back to this, and also, as we move into, the business process modeling and those other things, I think there'll be a lot of opportunity to weigh in on it and to refine it and to make sure that we have a clear model of where and how and who and when and, how do we actually do this? Because go back to the earlier part of the conversation, if we can do it in California and New York and Colorado, then that's pretty awesome. So we'll keep working on that. I think that's it for today. We're trying to get BPM Plus on one of the next calls. I also have on June 6th, I think it is, we have June 8th, our partner who presented to the Data Funders Collaborative, Elizabeth Laird from the Center for Data and Technology, CDT, Center for Democracy and Technology, sorry, Center for Democracy and Technology, will be talking a lot about the ethical issues associated with data and making sure we're practicing, and her specialty is in education. So bringing back into the conversation should be interesting. So we have BPM Plus, we've got her coming up to speak. And then I suspect over the next couple of weeks, we're going to get some more direction from ONC about the August workshop. And we'll hopefully just spend the time, use this time to really, sort of work the agenda or presentations or whatever it is that we'll need over the next couple of months to be able to sort of help and to do that. And ideally, we'll be able to move into some kind of further along in the implementation and the planning as we've already been doing.
And we have in ICFIS, we have Mohammed Jafari, Dwayne Dakota, and Chris Sean from the VA doing a demo of the VA SDOH consent service that apparently they demoed at HIMSS. And that's another possibility. We might be able to lure them in June or late July, or early July rather.
Yeah, so for folks who have relevant subject matter experts like the Cardia folks, we meet every week with AWS. I'm trying to bring our life sciences folks from Microsoft into the conversation. Hopefully sooner or later. Tomorrow we are meeting with San Diego and the state of California folks on basically what Robbie presented before. So a lot of stir and a lot of soup stirring. So with that, the stalwarts remain. I will end the conversation. We'll post this and talk to you guys next week.
Bye, everybody.
Take care, all.